So for the first 3 or 4 years after I got to the Mind Institute, I was studying regression and was working with a team of people, including Robin Hansen and Sally Rogers and some others, to really try to understand how autism signs first begin. And as we'll talk about later, traditionally the way that we've done that is to take children who have already been diagnosed with autism and interview their parents, or go back and watch video of them when they were younger to try to understand how autism starts. Then, in around 2004, I was lucky enough to be funded to carry out a study of infants who are at high risk for developing autism because they have a sibling with it. And this study we were sort of conceptualizing as one that was looking for the earliest risk factors so that we could identify children earlier. But of course, what we were basically doing was studying how autism starts, just like I'd been doing retrospectively for the first 4 years. So what I'm going to do is talk about these two research programs and really how they've converged over the past decade for me, and how they have, in fact, really made me start rethinking how autism starts in a way that I absolutely didn't anticipate when I wrote either of the grants. So, probably am very much preaching to the choir here, but there is a reason for doing this kind of work, and that is that most of the interventions that we know that are most effective for autism really require having a diagnosis. And so the earlier we can identify a child, the earlier we can institute these kinds of effective treatments. Now, the mean age of autism diagnosis still today, it varies across study and across region, but is between 34 and 61 months in different studies. And I did look up 2 different but very recent studies just for this talk to be sure I was still right about this, both published in 2009. One was from the Centers for Disease Control, and a very large epidemiological study that still found that the age of autism diagnosis was over age 4. Now, this is old. I mean, this is much, much after we think we can diagnose autism reliably, and even further after parents are telling us they knew something was going on. So we know we could really improve the situation. Parents across studies usually have an average age of first concern of about 18 months, but again, depending on the study, between a third and half of parents tell you that they had worries about their child before they even turned 1. So first I'm going to tell you sort of an opposite chronological order to how I did this in my career, but a little bit more about the infant sibling study that was talked about a tiny bit this morning in the keynote. Same purpose as I mentioned earlier, because if we can identify these babies, we can actually send them to treatment when they're still infants and potentially make a really big impact on their development. So this study is a collaboration between UC Davis and UCLA. We sort of split the funding across our sites and collect a large group of infants at each study, at each site, that is. And we have 4 goals for the study. One is to find out if infants who have an older sibling with autism are at higher risk for developing it, and also do they have other developmental problems. So if they aren't diagnosed with autism, are there a range of other impairments that are seen in those siblings? How early can we reliably diagnose autism, and what are the earliest signs? Maybe not the full diagnosis, but the very first symptoms or behaviors that we see. What are those? So the first phase of this study began in 2003, and we studied about 225 children who had an older sibling with autism, and about 125 who had a only typically developing older siblings. And we saw them 5 times, and then when they were 36 months old, we assessed them to determine whether they had autism. And I should say that if we notice signs of autism any earlier, at any of these other ages, we actually would make a diagnosis early, but everybody got a full workup at 36 months of age to determine if they met criteria for autism. And then we were funded again. We're in the middle of that period right now, and so we're following those first infants out when they're in school age so that we can, number one, see, did we get the autism diagnosis right for those we diagnosed so early? Number 2, did we miss anybody? Number 3, do the children have any other issues that wouldn't have been apparent at 36 months, such as learning disabilities, depression, anxiety disorders, those kinds of things. And then we also are studying a new group of siblings of children with autism and typical development. So we now are accruing a really rather large group of these high-risk infants. I'm not going to say a lot about this, but this just tells you about the sample, and you can see that it's a sample that's roughly half male and female. They're mostly a full-term sample, and we have a very nice distribution of ethnic and racial groups in the study, and about a middle-class level of income for both groups. We have a big battery of measures. It takes roughly 2 or 2.5 hours to assess each child, and it's across these 4 areas that we're particularly focusing on. So of course, because of the relevance to early autism diagnosis, we are looking at their communication and their social development. We have a very high interest in how they process faces, and so we have a variety of eye tracking tasks that look at that, and that look at some other things like speech perception. We also, of course, use the standard battery for diagnosing autism, and then we have a variety of other things that we cover. So we look at their motor development and their adaptive functioning and their head circumference and a whole variety of other things like that. We do have some things I'm not going to talk about today, but where we are doing some tasks that really don't seem very related to autism, like looking at their visual skills. For example, how well they can track objects as they move across a screen, or how well they can distinguish between light and dark gradings. And that's because we're interested in whether there might be some very early signs that don't even look like autism, but might predict who's going to look like they have autism within the next 3 to 6 months. So we're not just trying to pick it up in the ways we already know autism looks like at 2, because there's maybe a possibility that it looks real different at 6 months. So that gives you just a sense of the breadth of the battery. All right, now I always start with this because people are very interested in wanting to know the bottom line. Well, how many of those infants do develop autism? And this is at our 2 sites, UC Davis and UCLA. We found that 17% of the infants who had an older sibling with autism developed autism themselves. And this was contrasted to 3% of those who didn't have an older sibling with autism, and then you've probably heard the general rate in the population, which is a little bit lower than 1%. So obviously 17% is much, much higher. The previous estimates were, and these were based on studies from the 80s and 90s, were between 3 and 10% of siblings were thought to develop autism if they already had a sib with it, and so this is even higher than that, of course. Now, about a quarter of the sample had other things going on. For example, speech and language delays, that's the most common. And then occasionally we saw other things. In a few children, we saw very severe sort of social anxiety and separation anxiety, but yet the social phenotype didn't feel at all like autism. So some different kinds of things like that. And then about 2/3, a little bit less than 2/3 of the sample was developing typically. Now, we're also at UC Davis and UCLA part of a larger consortium, which is called the Baby Siblings Research Consortium, the BSRC. And it's actually a voluntary network of all the sites around the world, actually, that are conducting infant sibling research. So all of us doing this kind of work, we get our own funding, et cetera. But once we've gotten funded, we're invited to be part of this network. And when you agree to be a member of the network, you agree to deposit in a database any measures that are sort of commonly given across studies, so that then we can pool the data across all these sites and look to see, look to answer some questions that are much better to answer on a really large scale than on a small scale, like would be done at any single site. So we have a paper coming out. It's going to be coming out on August 15th that is going to include all the data that I'm talking about here. But 12 sites of the BSRC, which is actually much larger than just these 12 sites, but 12 sites had an appreciable group of infants who'd reached 36 months of age so that we could tell if they had autism or not. And those 12 sites pooled their data so that we had 664 high-risk siblings, so a very large group, and 338 low-risk siblings. And we found in that study, which obviously has a much better, more reliable estimate given that it's much higher than our single site, a pretty similar number. So 18.7% versus we had found 17% here developed autism or ASD in the high-risk group. The published paper is only about the high-risk infants, but there were low-risk there. I'm not going to talk a lot about them today. So that was the overall rate. But what we also found is that there was an elevated rate for certain subsamples, so even higher than the 18.7%. So if you, that was across both genders, but when you broke it down, male infants had 3 times higher risk than female infants. So the overall risk was 18.7%, but the risk to males was about 25%, you can see. So about a quarter of the time, if you had an older sib with autism and you're a male, they developed autism, whereas it was about 9% of the females. So much elevated risk if you were a male. We also looked at whether they had more than one sibling with autism, because some of the sample did have what we call, they were called multiplex families. They had at least 2, and in a few cases, 3 or more siblings with autism. So in those cases, we wanted to see if the risk, again, was elevated, and we found that given the overall risk, like I said, was 18.7%, but if you broke it down into multiplex families, the overall risk for the multiplex families was 32%, and then if you look at it here on the slide, you can see that if you were male and from a multiplex family, your risk is about 45%. So if you have 2 kids with autism and you have a boy, you have almost a 50-50 chance of that child having autism, which is incredibly high. So these are really important data. I'll come back and talk more about their clinical implications at the end of the talk. All right, so what I'm going to do now is walk you through some of the things that we found to be early indicators, and each of these are published papers already, so where we were able to take an early sign and look at how predictive it was and how many of the children who developed autism showed that sign, etc. One of them is a really simple thing. It's something that you hear parents talk about. I think, in the retrospective literature, that was probably the most robust finding, is that the parent would say it was almost like he or she was deaf. They just didn't respond when we called their name or when we spoke, but we knew that he wasn't deaf because if we crinkled a candy wrapper or he heard the garage door go up, then he would come running. So response to name was one of the things we really wanted to test prospectively, to see whether, if we were getting these serial longitudinal measurements of response to name, that would help us predict who was going to develop autism. Another one of the tasks that we found to be very predictive, and this was something we published 2 years ago and that Lori Vismara in her keynote address referred to, is something we call the object exploration task. And so what this task is made up of is just 4 simple objects. We looked at a variety of different ways they could be used. And so then when we looked at what these infants did at 12 months of age and how well it predicted their outcomes, we found out that there were all of the atypical uses of the object, 3 out of the 4 of the atypical uses of the object really helped predict who was going to have autism. So what we have plotted in blue is the group with autism who eventually is diagnosed with autism. And in the pink are children who are identified ultimately with other kinds of delays, like speech and language delays, and then in yellow, those who are typically developing at outcome at 3 years of age. And this is their data from 12 months old. And you can see that the children who developed autism rotated a little bit more than the other 2 groups, but that's not a very big difference. But what they did a lot of is that spinning, wobbling thing that I just showed you. And also, they did a lot of visual exploration of the objects. And they did, you can see, almost 4 times as much of it as kids who didn't develop autism. And so what that behavior was like was basically taking an object and staring at it for over 10 seconds. So we didn't even turn the code on until they'd already been looking at it for 10 seconds, and then looked at the duration after that. So this was essentially a staring at of objects, and occasionally sometimes rotating it and looking at it from different aspects. And those two behaviors, the spinning and the unusual visual exploration of the object, significantly predicted which babies were going to eventually have a diagnosis of autism when they were only 12 months of age. So, just to make a long story short, because in fact we had a huge battery, and I'm not going to go through each of the tasks, what we found is that pretty much nothing discriminated the groups at 6 months of age, but everything did by 12 months of age, and then at older ages. So no matter what we looked at 6 months, the infants looked pretty typical, those who are going to go on to have a diagnosis of autism. But by 12 months of age, so somewhere in that 6-month period, those same infants were beginning to show signs such that there were now significant group differences between those who went to have a typical outcome and those who went to have an autism outcome. And I'm not going to go through each of the different measures there. Another thing that we did is we undertook what we called a chart review, looking for when, for each particular infant, we first began to be concerned about them, and then when they were diagnosed. And this is now where I'm moving into the second phase, where I wanted to talk about onset. Okay? So what this chart shows is the first 13 children who were diagnosed that we did this chart review for. And if it's blank, it means they didn't come in for a visit at that age. But you could see that of the 5 children who had a 6-month visit, 4 out of the 5 were judged by the examiner to have no concerns. The parents had no concerns about them, and all of their developmental testing was completely normal. They were absolutely in the average range on everything we gave them. There is one child who did go on to have a diagnosis who we did mark with some concerns at 6 months, but they were only motor concerns. And it was specifically written out that there were no signs of ASD, and it was a very social, sort of really engaged baby. Now at 12 months, you can see that about half of the infants now have been picked up, where we are actively tracking and monitoring them and beginning to wonder if they are going to have autism or if they might already have autism. But you could also see that another half are still presenting essentially normally. So to get a green in this chart, you had to have no parent concerns, no examiner concerns, and no developmental testing outside the average range. And then you could see by 18 months, every single one of the kids had been made it onto our radar screen, I guess you could say, so that we were tracking them if they were in yellow, or in a few cases had already diagnosed them. So I think there's a couple of things that are interesting to me on this, and I'm going to come back to all of these points, I think. But one is just that there were so few children showing concerns at 6 months, and even that only half had concerns at 12 months. When I started this study, I thought, and very non-humbly, that if an autism expert saw babies who were ultimately going to have a diagnosis of autism, that we would definitely be able to tell. And I thought that we would be able to tell at 6 months, but certainly I thought we would for certain be able to tell by 12 months. And so this was really a big surprise. Like, these were infants, they were leaving the lab, and we were saying, oh good, he's fine. Oh good, he's fine again, and then next time they came back, they looked different. So that was one thing I think that had been very surprising. A second thing, and it's sort of related to this, is you see there's a few kids whose cells don't turn red until 36 months. And I certainly thought that given that that was our expertise and that we were specifically trying to make the earliest diagnosis possible, that we would have very few children who would be diagnosed at 36 months of age. But being part of this BSRC, this consortium where we've looked at this, our rates were actually lower than some of the other sites in terms of how often a diagnosis wasn't made until 36 months. So we had a pretty good track record, as it turned out. So I think that was a second surprise, that really for many children, there's a very subtle and protracted onset period where it's really not clear what's going on with them. And so we'll talk about that too as we keep going. Alrighty, so now I'm going to sort of shift gears a little bit, but we will certainly be coming back to this infant sibling work. But I want to talk to you about what we know so far about onset patterns, and then how the work that I've just described has made me really rethink that. So, as all of you probably know, in the DSM-4, it states that symptoms need to be present by 36 months of age. And the traditional view is that this happens in two different ways. One is that the child shows signs from early in life, doesn't actually say by what age, but typically thought to be the first year of life or so, first year and a half of life. And so they have some clear differences and delays. And then the second group seems to be developing just fine, going along for a year, year and a half, 2 years, and then has an abrupt and rather catastrophic loss of acquired skills. And so this is what we used to think of, and maybe some people probably still do think of, as the way autism starts. In the early onset pattern, these differences, which have been now validated in dozens and dozens of different studies, focus on things like attention to people's faces and looking at eyes, responding to name, pointing and showing and giving and requesting, joint attention, things like trying to share their interests with another person, and sharing their affect, when they're happy, smiling at another person, and when they're sad or distressed, sharing that with another person too. So pairing facial expressions with eye contact. And differences in all of these different variables have been found in children who have, quote unquote, early onset autism. Okay, regression. Now, across multiple studies, actually 24 studies, the average age of regression is right about 18 to 20 months. Sometimes it can occur earlier in an individual child. It's been documented to occur in the first year of life, and it can occur later, anytime obviously up to 36 months, but the average is right around 18 months. In most cases, it's a gradual start to the regression. So very few parents will tell you it was sort of an abrupt, almost overnight or in a week or two. Occasionally you definitely hear that, but it's a much more rare presentation also. Usually the parents will say something along the lines of, we didn't even realize it for months, and then we started saying, didn't he used to do this, or at Christmas, wasn't he pointing at things? And they sort of slowly come to recognize that things are diminishing. So a very gradual course is often described by parents. And what happens is both they're losing acquired skills, so losing the ability to point or to imitate or looking at faces and eyes, and then they're also having the onset of atypical behaviors that shouldn't be present. So then they're having the start of things like spinning objects or flapping of the hands or something like that, walking on toes. Now, in this study, we coded, as I say, all of those behaviors, and what you can see, here's a particular child with a regression, sorry, and you can see here his language starts off, you can barely see what these axes are, but it goes in developmental periods of 6 months, where each little crosshatch is. And so you can see there's very little language, and then it increases as it should in normal development, and then right about there where there's the regression, it drops off to almost nothing. Similar with pointing, they don't point very much in the first 6 months of life, but increases over the next few months up until 12 and 18 months, very high, and then he has a regression and it's dropping off. Same here, eye contact is at high levels, and then when he has a regression goes through a precipitous drop. And repetitive behaviors, almost none, and then a huge spike after the regression where he starts having a lot. So this is actually empirical coding of the exact frequency and duration of these behaviors in the home video, where you can really validate what the parents were telling you. And for a long time, I think nobody questioned that the parents weren't right about a regression, but it had never really been validated through video. And so now there's been several studies, ours is one of them, but there have been probably 3 or 4 others that have showed that you can clearly see evidence of regression on video. Just to say a little bit more about what happens in the regression, if the child has developed language, which it depends upon the timing of the regression, they'll usually lose most or all of their words. So it's rare for a child to have the kind of regression that we're talking about and retain language if they have it. Now, not all children lose language because sometimes they don't have any to start with. If their regression's at, say, 14 months. The social losses are not the easiest for parents to report necessarily, but I think from watching the videos and from doing this large-scale study, they're the ones that are the most potent, because you go from seeing a child who's looking at people and is very warmly engaged with them and is really interested in people to not being that way, to a child who then starts focusing on objects and really losing their drive or their motivation to interact. It's actually pretty rare in the regression for the child to lose motor skills, and you can see there that second little boy was, running around and still, hadn't lost any motor abilities. Oftentimes, a lot of times this happens prior to toilet training happening or prior to a child being able to dress themselves or feed themselves. So losses of those types really are fairly rare. It's really mostly in the social and the communication domains. And they tend to occur together, so it's, if a child loses words, they're going to lose social abilities, pretty much without a doubt. There has been in our field a bit of a controversy, although I think it's maybe going away at this point, but about whether it should be required for a child to lose language in order to be considered to have a regression. So a couple of really important studies were done in the early 2000s where they compared children who did lose words in their regression to children who had a regression and didn't lose any words because they didn't have any. And they found that they really weren't different in any way. So they didn't differ in their gender, they didn't differ in their age at regression, they didn't differ in what skills they lost other than the words, they didn't differ in whether they had seizures or not, anything else. And so now I think the field's come to really realize that regression is regression. It doesn't matter if it involves word loss or not. There are sometimes now studies that will look at what they consider narrow definitions of regression, and those are ones that require speech loss, and then broader definitions that require only social losses. And so how often do regressions occur? And again, this is based on these traditional definitions. I'm about to refute some of this, but in some large epidemiological studies, community-based large sample studies that were done, they found between 1/4 and 1/3 of samples had a regression. But in a study that was done by Robin Hansen and the charge team here at the Mind Institute, we found, and I think this makes really good sense, that the prevalence of regression was really, really impacted by how you defined it. So if you were going to use that narrow definition that required speech loss, regression was even less common than these studies had found. Whereas if you included social losses, quote unquote, only, because obviously that's still a huge loss, it was maybe even higher than some of these other studies had earlier predicted, maybe as high as 40% or potentially higher. So we're left with a little bit of a range, but at least based on these traditional definitions, it looks like less than half of children have a regression who go on to have autism. Quickly, I wanted to mention that it's really not sure how regression history affects prognosis. I think many times in the field there had been this assumption that if you had a regression, you would be lower functioning or you'd have less skills at outcome. But really the literature has not showed that. So there's been a whole bunch of studies that really don't find any differences between a regression and a no regression group. There's been a few studies that do find that children who have early onset autism have higher skills than those with regression. And then there's a whole bunch that have mixed findings, and what I mean by that is that usually they find no differences between the groups on almost all the dimensions, but maybe they'll find one test where the regression group's lower, something along those lines. So it's really, at this point, my thinking, my translation of the literature is it's uncertain whether how autism starts affects the child's outcome. Probably more influential are things like access to services, good services, early services, and that kind of thing. So now what I want to do is pull in some of that infant sibling work and tell you where we're going with it in terms of onset. Now there have been some problems that have been noted with the way that we think about regression, particularly in those retrospective designs that I talked about. Those are designs where the child already has autism, and then retrospectively you sort of try to reconstruct what their development was like prior to the autism starting, or the diagnosis. And the two ways that usually that was done was by interviewing parents or by looking at the video, like that study that I've been talking about that we did here, and it's been done in several other centers around the country. But there are problems with that. First of all, it is hard for parents to recall things that happened multiple years before. You know, ask any parent, and I'll just speak for myself as a parent who studies these things, that it's really hard for me to remember, you know, exactly when my children started to point, or what their first words were and things like that, unless I really go back and look in a baby book if I happen to write those things down. So there are some issues with parent recall. There have been some studies, in fact, some earlier studies 5 years ago that looked at the retest reliability of parent report of onset, and they found that it was pretty good, but that in maybe a quarter of cases, parent at one point would tell you that the child had a regression, and then when asked a year later, said they didn't have a regression, or vice versa. So, you know, there had been some studies suggesting that maybe it could be hard to recall some of this. Home videotape analysis is helpful. However, it's extremely expensive and time-consuming. It took us about 7 years to get all the results from the study that I talked about earlier. So it's not something you could do in a research project, you know, routinely to try to determine what a child's onset status was if you wanted to use that in a research project. So it's very lengthy. Also, not everybody has access to home video, you know, doesn't film their child. And I'll say again, as a parent, I know that when my child wasn't behaving the way I thought they should or looking real cute, I just turned the camera off, because why bother? You know, who wants to remember that? So you can't always be certain that you're going to be able to see what might have been happening in the child's development if you collect home video. So neither of these is exactly a gold standard that you can then compare the other two. Another problem with the sort of dichotomous view of onset is that parents sometimes tell you something else. They don't describe symptoms in the first year of life or a regression. For a long time, I remember as a clinician, I just thought it had to be one or the other. But, you know, you hear a lot of parents who would say things along the lines of, you know, they just seemed fine, and then they didn't go anywhere. You know, they didn't start making the gains that we thought they were going to make, and they just never got the language, and they never got the pointing, and they never got the this or that. And some people have called that a developmental plateau, and a few groups have written about it, including in Robin Hansen's paper, and some other groups at Yale and elsewhere have described this plateau phenomenon. So we know that there might be more than 2 categories. Maybe there's more than 3 categories. We don't know. But at any rate, some problems have come up with studying onset retrospectively. So, you know, now people are really thinking the way we need to study onset is prospectively, no longer taking the child with autism and then trying to reconstruct their history. Let's take a child who's at high risk of developing it and then figure out what their history is, what their course of development is right as it's happening. And so that's what we're doing in the infant sibling study. And so in that particular project, what we've done is we still are using some retrospective methods. So when the child's 3 years of age, we do the same parent interview that everybody uses to collect retrospective information about what the child was like when they were 1 and 2. So we still use that same method, but we're not doing this because it's way too expensive. But we now have some other things that we can do. We have longitudinal serial assessments that are done in the clinic. So 5 times over the course of the first 3 years of life, they've come to our study, and we're able to test exactly where they are in a whole variety of areas. And some of this is standardized, like looking at their speech and language development over time with a test, and then some of it is coding, similar to how we coded those home videos, but now we're coding what happens in the lab. So we're just saying this little snippet in the lab is like a snapshot of their development when they're 6 months old, and we use the same coding procedures that we use with the home video to look at the frequency of eye contact and how often they vocalize and how often they smile and things along those lines. We also have our examiners complete a form at the end of each session that not only rates concerns, like I talked about earlier, examiner concerns, but also just how social the child was. And they fill out sort of overall how responsive was this child, how hard was this child to keep engaged, you know, how often did this child look at me, how often did this child respond to their name. And we have a variety of things like that that we aggregate into an examiner summary of their social development at that age. Okay, so the first slide here that I'm going to show is the standardized testing. This is something that was published in the Journal of the American Academy of Child and Adolescent Psychiatry in 2010. The Mullen Scales of Early Learning is a developmental test. Maybe many of you use it if you work in clinics, early intervention clinics. And it tests both communication abilities, expressive and receptive language, as well as nonverbal cognitive skills, fine and gross motor skills. And I'm just going to talk here about expressive language performance. So what we have plotted on this blue line are typically developing children, and on the red line are children who developed autism. And in that group there are 25 on that red line. And so we plotted all the children who had at outcome, at 36 months, a typical outcome, against the children who were known to have autism at 36 months. And you can see that at 6 months, and I already showed you that in that summary slide, there's no differences between those groups. But by 12 months, they're already significantly different, with the sort of growth curve really flattening out for the children who are going to have autism. It's even more significant, so they've lost even more relative to the other group at 18 months, 24 months, and 36 months. So, and these are age equivalents that we have there plotted. But you can see that their development is sort of slowly falling off. Now, I don't have plotted raw scores here. You'll have to just take my word for it, but the graphs actually look really similar. So the children aren't actually losing language points. They're just slowing in their development in expressive language. Okay, so that's expressive language. Now, how about social development? So there's a variety of ways we look at this. This one that I'm showing you first are those examiner ratings. So this is where we took that scale that the examiner fills out at the end of each session. And by the way, the examiner doesn't know if they're in the high-risk group or the low-risk group, doesn't know what their previous testing was like or whether we think they might have any concerns, etc. And they just fill this out sort of quote-unquote blind to the child's group status. And so here again we have the children who have typical outcomes at 36 months and their social engagement ratings by the examiner. You can see they're pretty much flat. I mean, they increase a tiny bit over time. And then the children who develop autism, and you can see those just drop off. So they start off at almost exactly the same place at 6 months. So those babies are not distinguishable to the examiners at 6 months, but then already by 12 months, there's a significant difference, and it just declines precipitously over time. So they're rated as increasingly less social by the examiner each visit they come in. This is coded gaze to faces. So here we have coders who in a very painstaking and also labor-intensive way, code the frequency with which the baby looks at the examiner during the session. And they visit the lab 5 different times. And so you could see again, those with autism, and in this case actually are higher. It's not a significant difference, but those who develop autism have just as much, and in fact a little bit more, eye contact at 6 months with the examiner. But it drops, in fact, very rapidly at 12 and 18 months. It's already highly statistically significantly different from the babies who go on to have typical development at 36 months. So their eye contact, and this is exact frequencies. This isn't an examiner rating. This is actually counting the number of times they look at a person in a session, is just dropping off right away. So that looks like regression, right? Doesn't it? Okay, now overall, it's an average of 25 children. So what we wanted to do is try to figure out how many children showed that kind of decline trajectory versus how many sort of were early onset. It doesn't seem like we would have very many early onset cases in there, right, if their social development's that good at 6 months, but we wanted to look at that. So what we did is, we did this statistically. We computed what's called a confidence interval, a 95% confidence interval around the typical trajectory. So these dotted lines, if you were to shade in everything between those dotted lines there, that would cover 95% of all the data points of all the typical children. They all fell in that group, other than some 5% might be out here, out there, but 95% fall in there. And then we wanted to look at how many of the kids with autism fell outside that confidence interval. Now, out of the 25 children who are plotted in red, 22 of them had contiguous data. So occasionally a child would miss a session, and we couldn't look at this because they didn't have data. They went from 6 to 18 months. So for 22 out of the 25 children, we then wanted to see how many of them showed this declining trajectory. And what we found was that 19 out of the 22 fit on this line rather than showing a flat trajectory, and it wouldn't obviously be up high like in the typical group, but showing a flatter trajectory that would be more like early onset autism. So the declining trajectory was apparent in most of the children. And if you think back to that slide I showed you with the red, green, yellow, that's not surprising because we weren't seeing anything. Or if you think of also the slide I showed where we didn't see anything at 6 months, but by 12 months we were picking up group differences on every single one of our tasks. Well, that, by definition, feels or sounds like a regression, right? They're normal at one age and they're not 6 months later. And so this data just shows you even coding their exact behaviors during a session. We were able to pick up that the majority of the children were actually having a regression, but it was rather subtle. I would have to say that, sort of by definition, I think that my staff and myself would figure it sort of must be a regression if last time we saw Johnny he looked fine and now he doesn't. But on the other hand, it wasn't that we would go into a session and be like, oh my gosh, this child's having a regression. It wasn't that kind of hit you over the head. It was much more gradual. In fact, a lot of this took years for us to do because we had to code all that data. It was more that we'd say, just like the parents would say, didn't he used to point last time? Or gosh, I felt like he was fine last time. Actually, this was not usually the staff because they would be blind, but I would know because I would be at each of the visits watching. And where you'd start watching it sort of emerge before your eyes, but it was actually pretty subtle. Now, I told you we also got retrospective information from the parents. So then when the child was 36 months old, we did this interview where we asked about how the symptoms started, just like usually you do in almost all studies about onset. So we asked if they had, if there was ever a period in the child's development where they noticed them losing skills or getting, basically losing skills. And it turned out that only 4 out of those 22 parents reported a regression. All 4 of those parents who reported one were in the declining group, but there was a large group of parents who said, no, he was either he was always like that, or they reported that more plateauing phenomenon where they said, he seemed fine, which by our data he was, and then he never made the jumps we thought he was going to make, which he didn't. But what they didn't really get as much was that he used to make bright, sunny, warm eye contact and look you right in the face and smile and babble while he was looking at you. And he did do that, and now he's not. And so they didn't feel that or see that as a regression, or at least they didn't report it on this interview in that same way. So it's really gotten us thinking about what is a regression, and is regression a lot more common than we thought it was? You know, maybe is regression the way autism starts? It's not like there's 2 categories or 4 categories or 3, but that there's sort of a continuum of regression. And sometimes it occurs so early that it appears sort of like the autism's always been there. And then other times it occurs later where a lot of skills really have developed, so it's much more noticeable and much more marked. And I don't know if that's true or not, this is just a hypothesis, but it's really made us start to wonder if in this study, 19 out of 22 children, that's 80%, you could document a regression through serial longitudinal assessments, that maybe it's much, much more common than we ever thought, but it's really only identifiable through a microscope, not through the typical ways that we think about it, which is, you know, huge overt behaviors that parents would notice and then remember and tell you about 3, 4, 5, 6 years later when you're doing an onset interview. So just a hypothesis, but I think that whether this is right or not, our data certainly suggests that regression is a lot more common than we thought it was. All right, so let me pull it all together now, wrap up. First of all, going back to the infant sibling project and our goals, what do we know are the answers yet at this point? First of all, yes, they are at much higher risk, especially males and especially those who have more than one older sibling who are affected. There are other developmental problems. I didn't talk about this a lot, but it was in those initial tables, especially language delays affect up to another 25%, I think, of the sample beyond those who have autism. We can first start seeing the signs somewhere between 6 and 12 months. And I've actually put 9 and 12 months here because in our new project that's been going on now for 3 years, we actually see the babies every 3 months. One of the things we learned from the study is 6 months is an eternity, and we missed a lot of things that were happening. So now the babies come at 6, 9, 12, 15, 18. So you see them every 3 months and then 24 and 36. And I'll tell you, we still very, very rarely see 6-month-olds that look affected, but we do see 1 or 2, but out of hundreds. But we see some 9-month-olds, and we definitely see a lot of 12-month-olds. So I think that we're narrowing that period a little bit in our newest study. And I think that the things that when somebody asks me what are the earliest signs that you've found, I would say response to name, and then in particular, this decreasing pattern of eye contact is one of the very first signs that we're seeing. So, Kanner once talked about autism being present at birth. And like I say, gosh, now I think that's so wrong, but I just remind myself, when I went into this study 8 years ago, I actually thought that myself, at least in most cases. And it's really clear that that's not true now. I think that there's been probably 7 or 8 published studies that have looked at 6-month-olds at risk for autism, and they all find exactly what we've found. There's not been a single study yet that's found a marker at 6 months of age. So I think it's pretty clear that some children can show signs early, but as the vast majority as a group look relatively intact socially at 6 months of age. So it's emerging over time. Losing skills might be much more common, but it's actually pretty difficult to observe in real time and to capture by asking parents about it. So what are some of the implications of this work? First of all, we think that given this real protracted period in which the autism signs are emerging, that infants need to be offered interventions before they meet the full diagnostic criteria, because that can sometimes take 6 to 12 months. And so that's why we're partnering with groups like Lori Vismara, and Sally Rogers and many of the other BSRC sites, this consortium I talked about earlier, are paired up with treatment projects because we want to be able to offer interventions absolutely as early as possible to see if that can head off the signs. Now, you guys saw some video this morning of children who made really marked improvements in their time in those studies, and those were infant siblings. Those came out of this study. These, in fact, their data were on these slides. But you could see that in those particular cases, it looked like maybe we did head off autism in a few of them. I mean, certainly if you think of the one little boy in the high chair task, at 9 months, that looked like autism to me. I don't know what you all thought, but certainly when we saw him in the study, we referred him right away. But even just rewatching it today, it's been a long time since I've seen that. I thought, well, I did think that was autism and he was going to have it, but he looks actually very good now. You know, time will tell. He's not old enough to know if he's fully out of the woods, but I thought he had a remarkable change in his behavior and his developmental trajectory. And so that's why we feel like even if you're not sure, it's worth getting intervention. We're continuing to try to figure out, though, if there are any signs at 6 months or even earlier than 6 months, because it is possible that there will be something that's different about those babies, even if their eye contact is great and their smiling's great and their social engagement with people seems fine. Maybe there's something else there that's going to trigger them looking really different within the next 3 months. And so we're really trying to explore multiple different variables, from visual and attentional variables to just very early signs of speech processing, et cetera, to see if we might get a clue. And unfortunately, I don't have any data to show you yet on that, but whether we could predict who's going to start looking bad at 9 months or at 12 months. And then finally, we really do need to screen multiple times in the first year of life to be sure that we pick up children, because you can see again with this protracted emergence that if you just do it certainly just at 12 months, you're going to miss a lot of kids. If you just do it at 18 months, you're going to miss a lot of children. I'm not going to go over all this. It's sort of a summary of the entire talk, but I keep it in your slides so you have it there as handouts about the kinds of things that across multiple infant sibling studies are being validated as the earliest signs. You know, so children who might have some really early signs of autism won't be doing these things at 6 months. Most of them will. But then at those who are developing autism in this period, these are the kinds of things you'll see that maybe they're not doing. Or these are the kinds of things you should be checking to see if babies are doing, and if they're not, worrying about. So those I have in your handouts just for your future reference. Same here. I'm not going to go through it because I don't know that it's relevant to everybody in this room, but I would be happy to take questions about it if you want. But I've listed the screening tools that are currently available and useful for infants. These are both broadband screeners that can pick up lots of other types of developmental delay but would include autism, and some that are very specific to autism. But these are ones that are specific to infancy, the ones that I've listed here that are used for below 2 years. All right, the American Academy of Pediatrics recommended in 2007 that pediatricians should be routinely screening for autism and performing screens for it at 18 and 24 months of age. And certainly our work suggests that that is the right thing to do. And then finally, I just want to close with what we've learned clinically through this work about partnering with families to figure out onset and to figure out the earliest time of diagnosis. First of all, and this is something I didn't have time to talk about, but it does come out of our lab, we looked at how early parent concerns predict autism. And it turns out that they don't predict at 6 months, just like all the other things that we've looked at, but by 12 months of age, if the parent tells you that they have one concern that falls into this group of concerns that we call ASD-related concerns, communication, social, any kind of repetitive behavior, or they just say things like, I just don't know why, but I feel like it could be autism, or he's reminding me of his brother with autism. If they say even one of those things, that predicts at a pretty high sensitivity level children with autism. Now, the specificity of it isn't very good, because sometimes parents will say that and then the child will be fine. But if they do say that, many of those children go on to have autism. So it's fairly predictive, and it's certainly very sensitive. It's actually fairly unusual that a parent doesn't bring up those kinds of things and then they go on to have autism. So if a parent tells you that, I think the main point here, that alone can't be used for a screening tool. But if you're a professional and a parent tells you, I'm worried about this, you need to listen to that because it has very high sensitivity. Now, we also, you saw that sort of green, yellow, red table there. It takes us a while to figure it out for some of the children. And so we feel when we talk to families, sometimes that we need to be certain, but the point is we aren't sometimes. And I've learned over 8 years that sometimes, in fact, a lot of the time, we say to parents, we're actually really not sure. We're a little worried. We're seeing some things that sometimes babies who go on to have autism do, but sometimes they're fine. And we just need to watch your baby really closely. Why don't you come back even before the 3 months are up and we'll track him with you, etc. And so we're really honest about how imperfect our prediction is, and we could be wrong, but we also bring it up fairly early, even if we might be wrong, because families have different values. Some families are like, I'm comfortable waiting and seeing, because, it's a 9-month-old. Sometimes and we're really not sure. Other families are like, I don't care. I don't care if you're completely wrong. We want to get intervention today. Refer us. So we do try to sort of gauge the family's values and what they want, but the best way to do that is to be open and honest with them about what we're seeing. And then these are in your handouts for later, but I've given you some of my favorite books about early intervention and some of the best websites, early identification, that you can go to and that have really wonderful resources for both families and for professionals. So I'm going to close by thanking my team. This is something that it really does take a village to do. I've got a wonderful group of people that I work with who have really amazing clinical skills and who've collected some amazing data. Thank our funding sources, and most importantly, thank the families, because these, for all families in this study, is a vulnerable time. Even for the families where the baby turns out fine, they're waiting and worrying, and it's a very tender time of life for their babies, and we really appreciate that they let us into their lives in the way that they do. So thank everybody for coming, and I'll be happy to take 1 or 2 questions before we end up. Thanks.
The UC Davis Mind Institute was created in 1998 with a promise to find cures for neurodevelopmental disorders. Every day, our physicians and researchers come closer to fulfilling that promise. Their groundbreaking research on autism, Fragile X syndrome, chromosome 22q11.2 deletion syndrome, ADHD, and other brain disorders are helping children achieve their fullest potential. Please visit our website to find out more about current studies, upcoming events, and how you can help make a difference.
Because we're interested in whether there might be some very early signs that don't even look like autism, but might predict who's going to look like they have autism within the next 3 to 6 months. So we're not just trying to pick it up in the ways we already know autism looks like at 2, because there's maybe a possibility that it looks real different at 6 months. So that gives you just a sense of the breadth of the battery. All right, now I always start with this because people are very interested in wanting to know the bottom line, well, how many of those infants do develop autism? And this is at our 2 sites, UC Davis and UCLA. We found that 17% of the infants who had an older sibling with autism developed autism themselves. And this was contrasted to 3% of those who didn't have an older sibling with autism, and then you've probably heard the general rate in the population, which is a little bit lower than 1%. So obviously, 17% is much, much higher. The previous estimates were, and these were based on studies from the 80s and 90s, were between 3 and 10% of siblings were thought to develop autism if they already had a sib with it. And so this is even higher than that, of course. Now, about a quarter of the sample had other things going on. For example, speech and language delays, that's the most common. And then occasionally we saw other things. In a few children, we saw very severe sort of social anxiety and separation anxiety, but yet the social phenotype didn't feel at all like autism. So some different kinds of things like that. And then about 2/3, a little bit less than 2/3 of the sample was developing typically. Now, we're also at UC Davis and UCLA. We sort of split the funding across our sites and collect a large group of infants at each study, at each site, that is. And we have 4 goals for the study. One is to find out if infants who have an older sibling with autism are at higher risk for developing it. And also, do they have other developmental problems? So if they aren't diagnosed with autism, are there a range of other impairments that are seen in those siblings? How early can we reliably diagnose autism? And what are the earliest signs? Maybe not the full diagnosis, but the very first symptoms or behaviors that we see. What are those? So the first phase of this study began in 2003, and we studied about 225 children who had an older sib with autism, and about 125 who had a only typically developing older siblings. And we saw them 5 times, and then when they were 36 months old, we assessed them to determine whether they had autism. And I should say that if we notice signs of autism any earlier, at any of these other ages, we actually would make a diagnosis early. But everybody got a full workup at 36 months of age to determine if they met criteria for autism. And then we were funded again. We're in the middle of that period right now, and so we're following those first infants out when they're in school age so that we can, number one, see, did we get the autism diagnosis right for those we diagnosed so early? Number 2, did we miss anybody? Number 3, do the children have any other issues that wouldn't have been apparent at 36 months, such as learning disabilities, depression, anxiety disorders? Those is a reason for doing this kind of work, and that is that most of the interventions that we know that are most effective for autism really require having a diagnosis. And so the earlier we can identify a child, the earlier we can institute these kinds of effective treatments. Now, the mean age of autism diagnosis still today, it varies across study and across region, but is between 34 and 61 months in different studies. And I did look up 2 different but very recent studies just for this talk to be sure I was still right about this, both published in 2009. One was from the Centers for Disease Control in a very large epidemiological study that still found that the age of autism diagnosis was over age 4. Now, this is old. I mean, this is much, much after we think we can diagnose autism reliably, and even further after parents are telling us they knew something was going on. So we know we could really improve the situation. Parents across studies usually have an average age of first concern of about 18 months, but again, depending on the study, between 1/3 and half of parents tell you that they had worries about their child before they even turned 1. So first I'm going to tell you sort of an opposite chronological order to how I did this in my career, but a little bit more about the infant sibling study that was talked about a tiny bit this morning in the keynote. Same purpose as I mentioned earlier, because if we can identify these babies, we can actually send them to treatment when they're still infants and potentially make a really big impact on their development. So this study is a collaboration between UC Davis and UC kinds of things. And then we also are studying a new group of siblings of children with autism and typical development. So we now are accruing a really rather large group of these high-risk infants. I'm not going to say a lot about this, but this just tells you about the sample, and you can see that it's a sample that's roughly half male and female. They're mostly a full-term sample, and we have a very nice distribution of ethnic and racial groups in the study, and about a middle-class level of income for both groups. We have a big battery of measures. It takes roughly 2 or 2.5 hours to assess each child, and it's across these 4 areas that we're particularly focusing on. So of course, because of the relevance to early autism diagnosis, we're looking at their communication and their social development. We have a very high interest in how they process faces, and so we have a variety of eye tracking tasks that look at that, and that look at some other things like speech perception. We also, of course, use the standard battery for diagnosing autism, and then we have a variety of other things that we cover. So we look at their motor development and their adaptive functioning and their head circumference and a whole variety of other things like that. We do have some things I'm not going to talk about today, but where we are doing some tasks that really don't seem very related to autism, like looking at their visual skills. For example, how well they can track objects as they move across a screen, or how well they can distinguish between light and dark gradings. And that's So for the first 3 or 4 years after I got to the Mind Institute, I was studying regression and was working with a team of people, including Robin Hansen and Sally Rogers and some others, to really try to understand how autism signs first begin. And as we'll talk about later, traditionally the way that we've done that is to take children who have already been diagnosed with autism and interview their parents, or go back and watch video of them when they were younger to try to understand how autism starts. Then, in around 2004, I was lucky enough to be funded to carry out a study of infants who are at high risk for developing autism because they have a sibling with it. And this study we were sort of conceptualizing as one that was looking for the earliest risk factors so that we could identify children earlier. But of course, what we were basically doing was studying how autism starts, just like I'd been doing retrospectively for the first 4 years. So what I'm going to do is talk about these 2 research programs and really how they've converged over the past decade for me, and how they have, in fact, really made me start rethinking how autism starts in a way that I absolutely didn't anticipate when I wrote either of the grants. So, probably am very much preaching to the choir here, but there